Niloufer. Please start. Presenter from Niloufer. Please start. You've not joined, is it?
Any connectivity problems? Must be.
Looks like it.
This is the case of abdominal mass.
Yes, yes.
Okay. Till the time he is joining, let me ask the residents who have joined. In what are the conditions which lead to abdominal mass at birth? It was, I think, discussed last time also.
Yes. Yes.
Let us revise. Are people able to hear me? Some of the residents, please speak.
Ma'am, once again the question, which is the mass?
Abdominal mass at birth.
At birth.
Neonatal abdominal masses, or whatever you can say.
This, and then residual mass, and we were happy to have in my hospital and do natural spine surgery.
There is a really severe problem with audio.
Looks like it. Is a presenter from Niloufer. Are you able to hear?
I think there was one message that there is a connectivity problem.
Yeah. Yeah.
Do we have some other standby person also who can present?
Prasuna is presenting, I think.
She had written, he has written, I do not know. That
Yeah,
there is some connectivity problem.
He has written, yes. Prasuna, are you there?
Is the problem resolved? Doesn't seem to have resolved. Okay. At least if other people, till the time he is able to join, we can, have Viva sort of a thing.
Yeah, I think we had to discuss H-type TEF operative procedure. Let us do that then.
Okay. Who is going to discuss?
Yeah. Someone please start H-type TEF operative procedure. We had stopped there last time. Or do I read out from here? I think Dr. Apurva is there. Apurva?
Please, residents, please revert back as soon as possible, because online we have to have a lot of patience.
Right. Apurva? Yeah, please. Say.
So, in a suspected case of H-type fistula, first we will arrange for doing a bronchoscopy. So, under bronchoscopy guidance, first we will reach up to the carina, and then slowly we will exit outwards and search for the fistula on the posterior wall of the trachea. So if there is a tissue, chunk of tissue seen on the posterior wall of trachea, we will try to pass a guide wire through that opening, and we will try to negotiate the guide wire via this opening in the esophagus, and we will, if
why will a chunk of tissue be seen? You mean a depression, a pit or something?
Yeah, a pit.
What else? How else do you recognize it? A pit? How else?
By bubbling, some
Yeah.
bubbles will
Yes.
be
Okay. Okay. Fine. So you'll try to cannulate it. Go ahead.
stimulated. Yes, sir.
Okay, let me ask one question.
Yeah.
Would you not like to do esophagoscopy rather than bronchoscopy
Yeah.
to
Uh,
identify? What is the advantage? What is the disadvantage?
Ma'am, esophagus is a collapsible or collapsible tube. So through a bronchoscopy, it will be more the
Okay,
success.
one is collapsible tube. Second,
Second, ma'am, along with bronchoscopy, the ventilation will be managed along.
No. More
no.
reason.
Okay, that can also be taken. What is third reason?
You have seen an esophagoscopy, no? So many mucosal
Yes.
folds. Is it easy
Yes.
to get a
No,
hole
sir.
somewhere to cannulate?
No, sir. It will be difficult to cannulate from
What else?
esophagus.
Simi wants more reasons.
Uh,
In what position do we do scopies? Is it is it in the prone position or supine position?
uh, we do it in supine position.
Okay.
Actually,
And
So,
yeah.
so quickly you must tell the answer. When an
yeah.
examiner gives
So
you a
yes, sir.
hint,
So
take the hint and quickly say.
so in supine position, it will be the bronchus trachea will fall on the esophagus, and
Correct. So to cannulate also from anterior to posterior. Another reason, one more reason. What is there something called H type or
yes, sir,
N type?
yes, it's the direction of the fistula is oblique. It's not.
Yes.
So, and it is also located on the anterior wall of esophagus.
Yes.
It will be difficult to do it with whatever rigid apparatus that you have, unless you have a flexible one which we can rotate on all sides, and then it may have will be difficult to cannulate, because flexible from the flexible there has to be a channel in which you have to pass the whatever the guide wire. Here, in a supine position, to see the anterior wall of any collapsible tube is more difficult than in to see the posterior wall of a relatively rigid tube. So it is always better to approach it from the tracheal side. And plus,
Yeah.
when you are doing the esophagoscopy, then already there is a tube there is ET in the in the trachea, so
Yes.
which can also block the which can also interfere with passage of any tube
Yes.
across. So these
Yes.
are the reasons why we prefer bronchoscopy. Okay.
Okay. So once I have cannulated the fistula, I will fix the guide wire uh, and withdraw the bronchoscope. Then I will plan for a for a operative for the repair of the H fistula. So for positioning the patient, I will place the patient in supine position with extended neck with head tilt towards the left side. I will take incision on the lower part of the neck above the clavicle, lateral to the lateral to the incision of the sternocleidomastoid.
On which side will you take the incision?
The right side, right supraclavicular region.
Why right side?
Ma'am, it will be it's easy to approach from there because on left side aortic arch will be there.
So high.
Yes.
Are we doing thoracic?
No, from neck.
So where is the aortic arch located?
Sorry.
On the left side, there is some structure which is not on the right side, which can make the exploration easy. Anyway, then you
I
You
will
have
read
to.
it.
Okay. Next.
Then taking the lower cervical incision in the supraclavicular region, I will dissect the sternocleidomastoid. Divide the heads of the sternocleidomastoid. I will retract. Actually, ma'am, I'm not sure.
Okay.
What is the usual location of cervical fistula on the trachea side where it
It's around
starts?
See, you have to reach the cervical esophagus, isn't it? Just like you do a cervical esophagostomy. So
Yes.
the steps are very much similar. Only after you reach the esophagus are you going to do the rest of the procedure.
That is what you should know.
Yeah.
That-
Yes.
So tell us that.
In cervical region, generally, where is the H-type fistula it originates? Maximum, the most frequent site of finding the this thing, H-type fistula, tracheal end.
T2 level.
वो तो thoracic हो गया ना? ठीक है, one part is correct. So it is between T7 to T2.
Yes.
Okay.
Yes, ma'am.
चलो. Okay, go ahead.
Actually, can I prepare properly and then answer later?
It's okay, doesn't matter. Go ahead. We'll guide you. Don't worry. Just go ahead.
Then I will, after dissecting the head.
So you are dissecting between the two heads of sternomastoid and you are retracting them and you have split the fibers. Yes. Then
I will.
As he has already told you, Dr. Kanishka, that as you do in esophagostomy, now you go ahead. Almost the same steps.
Search for the groove of the esophagus.
Yeah, but how do you search? Have you put something inside? Guide wire, no. Can't. Have you not put some other tube?
Nasogastric tube.
Correct. So you have a nasogastric tube, you have an endotracheal tube, you have guide wire much later. So you will take those as your feelers and try to isolate the esophagus.
Yes.
Right. So you have reached the esophagus. Next, what do you do? Continue.
So after reaching the esophagus, I will dissect in between the trachea and the esophagus. I will deepen the groove in between the esophagus and the trachea.
Yeah.
What are the difficulties that you are going to face? In order to reach there, you have to really labor very hard.
Yes.
And we use the important tricks.
The carotid vessel will be there, lying over it.
Between esophagus and trachea?
I thought before. No, in that vagus nerve, I will identify the vagus nerve.
We have presumed that you have reached the esophagus. Now further, that you have already retracted aside those carotid sheath and all that, and then
large vessels. Yes.
We presume that you have reached there. Now, what next?
So after deepening the groove of in between the trachea and the esophagus, I will try to put a feeding tube in between the trachea and the esophagus, and I will try to loop it.
If you can do that, I'll be very happy. And if you had ever assisted this, then you will know that it may not be feasible at all. Okay. So what structure lie between trachea and esophagus?
What is the structure which is there, which you have to be very careful about if you are going to sloop it?
Vagus nerve.
Vagus.
Or a branch.
Yeah, the branch.
More importantly.
Recurrent laryngeal nerve.
Okay.
Yes, that is there. Okay.
Fine. So you have to be careful about that. If you are going to sloop it, you have to stay close to the wall of the esophagus and then because it might be inflamed, inflammatory, etc., and gently sloop that. And you have to use the guide of that tube which you have put, the NG tube, right? Then how
Generally,
to
it is a
identify?
generally
Yeah.
it is a better strategy to loop the esophagus above and below the.
Yes.
where
So how will you
have
identify that? How will you
passed.
do that?
I will ask my anesthetist to move the guide wire, which I have inserted. Just I will ask him to
Okay.
move it. So
Yes.
in that way, I will try to identify the fistulous tract in between
Okay.
the esophagus and the trachea.
Okay.
So once I have got the access to the esophagus,
Yes.
on both the side, above the fistula and below the fistula,
Right.
I will take stay suture on the esophagus side
Okay.
and also on the trachea side on the fistula. So,
Okay.
Then after taking stay sutures, I will cut the fistula and ask.
Correct. So you have to withdraw. If you have cannulated, then you will gently withdraw.
ask
You
the
would have
intake
taken stays, and then you will close it.
Close it.
What suture are you going to use?
PDS.
Hello.
Yes, yes.
Hello. I will use PDS
Okay.
on
Okay,
the
you're going to use an absorbable suture. Acha. So you won't
Can you
use
use
proline.
some? Can you use non-absorbable also, and which one? On which
so
side?
proline on the trachea side.
Okay.
Yes. Which number?
40.
40 will be too big for a neonate.
Yeah, depending on what age you are doing it in. If it's a
Age of the
neonate,
baby
then
will depend. Huh? Okay.
Yes.
okay.
And on esophagus side, I will use a PDS.
Okay. Then what next?
Then after ligation of the fistula,
Ligation and division.
I
You
will-
have already divided, and now you are
Yeah.
suturing.
I
Conic
will
up.
insert a patch of muscle, in between the dent on the esophagus and the
Which muscle can you take from there?
sternocleidomastoid.
Acha. Okay. Anything else which is nearby also you can take?
A omohyoid or a platysma.
Okay. Okay. Right. All of them are acceptable. Yeah.
The sternohyoid and those strap muscles can be used.
Trap muscles. Yes.
Okay. What is the
Right.
what will happen if you don't use them? What is the problem?
Chances of reoccurrence of refistulation is there
Okay.
because the suture line will be overlying each other. So we want to put a buttressing layer in between.
Right. Then after that, do you leave a drain?
No, sir.
You won't leave a drain. Okay. I am a scared surgeon. I will leave a drain. A glove drain or something very mild, I will leave there. Okay. Then closure.
Not
So phone karo na.
then
Yeah, you wind up fast because they are ready there.
then I will suture the head of the sternocleidomastoid and and close the incision in layers.
Okay, fine. We'll come back to this later. Dr. Simi, is Dr. Shubha around?
Yes.
Fine.
Yeah, yes, sir. Am I audible?
Yes, Shubha.
Yeah,
So then
good
both
evening,
of you
sir.
can
Good
start
evening,
off.
ma'am. Yeah, I'm
They are
there.
ready. Okay. Yeah, start your mask.
One more question.
Yeah,
Okay. Once this is over, then what is the post-op follow-up in next time?
In the post-operative
How
period,
early you will start the feeds?
RT feeds I can start in after 24 hours.
Yeah.
Then I will do a diet study after 7 days.
Okay.
Oral
Okay.
contrast study.
Fine. And how long will you ventilate?
No, ma'am, depend upon, like, we don't have a strategy of elective ventilation in our institute. So if the baby is maintaining and doesn't require ventilator, so we won't ventilate baby.
Okay, that can
Oh.
be accepted. Okay,
Okay.
and supposing it recurs, then the fistula recurs, then what are the options that you have with you? How will you?
There's a fistula. Ma'am, I will keep the nasogastric tube over there only. I will.
Supposing it recurs in the follow-up.
Later
you
if
have
it
some
recurs.
you want to go again, or you have some other options with you?
Are there any other minimally invasive options you have?
Yes, I will. There is a clip ligation, bronchoscopic clip ligation.
More importantly, clip कहाँ लगाओगे आप?
Where will you put clip through bronchoscope?
Sorry, वो भी है. Let me know.
Anything you can inject into the area to obliterate?
Glue.
TCA.
Okay.
Piece. Yeah, a glue can be inserted.
Yes,
Injected.
that is also there, or you can even laser cauterize.
Yeah.
Okay, so you should know, you should be aware of all these things. That
Okay.
these are the options which are available. Okay.
Yeah, move to the case, Dr. Simi.
Thank you, ma'am.
Yeah. Yeah. Now
Thank
you
you,
can
sir.
start case I.
Good evening, sir.
Yes.
Okay. Can I share my screen, sir?
Yes,
regarding
please. Please start.
Sir, can the screen be seen?
Yes, it is seen.
Yeah. Sai, yeah, go ahead. Good evening, everyone. Today I would like to present a case of a 3-year female child with the informant being mother, who is a resident of Hyderabad, who presented to the department with the chief complaints of fullness in the left upper abdomen since 1 month. The history of present illness was noticed by the mother as fullness of the left upper abdomen 1 month ago while giving bath to the child. The mother later, after 3 weeks, the child presented with the history of fever, which was of low grade, intermittent, and not associated with chills and rigor. And the fever relieved upon taking medication. Am I audible, ma'am?
Yes.
Oh, thank you, ma'am. There was no history of diarrhea, no history of vomitings, and there was no history of any abdominal pain. There's no history of any jaundice, no history of any irritability or headache, and there is no history of any urinary symptoms. On past history, there were no similar complaints in the past. And antenatally, the child was born out of a non-consanguineous marriage. The mother had regular antenatal checkups and had taken regular iron folic acid treatment. And then on TIFA, there were no obvious anomalies. Her natal history, the child was a birth order of 2, who was a term child with a birth weight of 2.75 kgs, born out of normal vaginal delivery, and there were no history of any NICU admissions. Family history was nil significant, and immunization history, the child had a regular immunization according to the IAP schedule. Developmentally, there were no delay of milestones. On general examination, the child.
Wait. Summarize your history. What is the salient point? And I want other residents to point out if she has missed out on some points. Yes, please summarize.
This is a 3-year-old female child with an incidentally identified fullness of the left upper abdomen 1 month ago, with a history of low-grade fever, and the rest of the history being insignificant.
Okay. So any important point that anyone else would like to know? Please come up quickly. We are not
Ma'am.
facing you also.
Ma'am, history of vomiting.
There was no history of vomitings, ma'am.
I think she
about
took.
it.
Any history of jaundice?
There was no
She said-
history of jaundice.
Okay. So what I would like to know is, first of all, it is a low grade continuous fever, or was there any relief? Number one,
Intermittent fever, ma'am.
intermittent fever. Number two, was there any history of weight loss?
There was no history of any weight loss.
And third is, was there any ball of wind movement?
Ma'am,
Visible peristalsis, it is called in layman terms, ball of wind movement.
there was no such history, ma'am.
Okay. So, Dr. Kanishka, you want to ask anything?
No, I think Dr. Shubha is there.
Okay.
Sai, what do you think from your history? Can you deduce where the pathology is from?
As the fullness was noted in the left upper abdomen, and it was an incidental finding by the mother, and there were no other symptoms, I would probably think it to be a renal origin. Renal origin.
Renal origin, is it? And
Renal-
you think it's benign or malignant?
Probably a malignant
It's
etiology.
going on for a month, isn't it?
Yes, ma'am.
So you still have malignancy high on the list?
But it was the period of progression was rapid.
Okay. Yeah,
No,
well,
but,
I think it's very
did you-
difficult to deduce only from your
Ah.
history
Ah,
that
yeah.
you can localize the pathology to a particular organ. So I think you need to go ahead with your general physical examination and the systemic examination, and then we'll see where you're going to place it.
in the history, then you should mention that mother noticed the distension first in this thing, and now she's thinking that it is rapidly increasing. There has to be something. You can't presume that it is rapidly increasing, no? Not mentioned at all in the history.
I have told it orally, ma'am. Actually, she has identified it 1 month ago, after which they have noticed an increase in the fullness of that part of the abdomen.
Okay. I think I must have missed it because I didn't hear it. I just said, I just heard that it was identified very incidentally, and that is it, abdominal. Okay, supposing it was not increasing, the history was a little bit different. That it was noticed, and that is it. It is just 3 weeks history, no?
Yes, ma'am.
So if it is was not rapidly increasing,
Then we can think of any benign etiology.
like
Any related to any splenic lesions or
just now you said renal.
any other infective etiology.
Then
You must be very
No,
clear.
in renal, what would it
Ah.
be if it was supposed to be benign? Which is the commonest thing in renal?
Hydronephrosis.
Yes.
Yeah,
Yes.
secondary to PUJ.
Yes.
Anything else can also, something of renal can present like that in benign? Some lump there? Name a few benign pathologies which present as renal lumps.
Yeah,
one
commonest is
is
hydronephrosis. What else?
Hydronephrosis.
What
else?
next? The other one is also not so uncommon. The two things that we always think about in benign.
Which is other congenital renal condition which can present with a big mass like this and quite asymptomatic.
Will somebody else also say?
Lesions of the kidney, ma'am.
Excuse me?
Cystic lesions, multicystic disease of
Yes.
the kidney.
Okay. So
Yeah.
that's it. So you can have that also. Fine. Okay, now you say it was rapidly increasing, so you are thinking in terms of renal pathology, which probably a tumor.
Yes, ma'am.
Right in this left-sided, besides renal, what all things that you think could lead to tumor? What other DDs in your mind?
Uh,
If you are
others,
thinking of malignant.
uh, any retroperitoneal lesions could be there, and any other adrenal region
No,
lesions.
other than
That-
renal, which retroperitoneal? You're talking about a malignant lesion, isn't it?
Yes,
So
ma'am.
though the age is not so conducive, but then it could still be
Yeah.
there. So which is that? Which is other common retroperitoneal mass in children?
Retroperitoneal teratoma.
More commonly, I think you should take hint
Commoner
from
than
Dr. Shubha, whatever she's saying. It's very easy. You always keep it as a DD of renal.
Neuroblastoma.
Yes.
Yeah.
That is there, and then it could be some retroperitoneal.
Yes.
Okay. Fine.
yeah, continue with your examination.
On general examination, the child was conscious and coherent. She was moderately built and moderately nourished, and there were no dysmorphic features. The head-to-toe examination was normal. Her gait was normal, and the pallor was present. There's no icterus, no cyanosis, no generalized lymphadenopathy, and no pedal edema. Her height was 87 centimeters and weight was 12 kgs with a mid-arm circumference of 11 centimeters. And temperature, the child was afebrile. Blood pressure was 100 by 60 millimeters of mercury with a pulse rate of 94 beats per minute and a respiratory rate of
Whenever you tell about BP, always tell what is the normal expected. Is it above?
It was within the
Uh,
normal range for the age, ma'am.
No,
Okay.
how do you mention that when you have to actually precisely tell whether the BP was normal or it's high or it's low? It is quoted as what?
Some percentile?
It was within the 94th percentile for that age.
Okay.
Uh,
So you look for dysmorphic features.
yes.
You still have malignant as your first differential. So what dysmorphic features do you find in a malignant tumor?
I would look for any features of the eyes, ma'am, like aniridia or any raccoon eyes and
No, so dysmorphic features only in terms of eyes or anything else? Or I'll make it easier for you. You can just tell me what are the dysmorphic features if it was a malignant condition and what are the ones which you see in a benign one, say any CACUT. You know what CACUT is, no?
Yeah. These features one has to really look for if you are keeping as a DD as a some renal tumor.
Students का exam लेते हैं तो I'm just listening.
This is interesting for me also to listen.
Yes, how they present, no? They are over. Kanishka Das is quite famous for that. So I said, you rope me ill also. I also asked questions on them.
दरवाजा खोल दो नहीं?
Well,
Is there something said? I could not hear. It's not clear.
no, ma'am, I did not say.
You should have said, no? This is
Yeah.
there are few points which cannot be excused.
Yes, ma'am.
Okay, you should understand that. In a patient of renal where you are thinking about tumor and where the DD is also neuroblastoma, if you don't take BP, it is not excusable. If you are not seeing those syndromic features, it is not excusable. Then you have to know what all syndromes are associated and
Yes.
all that thing. So what now? Tell me what you have missed, which you should have seen. If you are thinking Wilms or any renal tumor.
Uh, I
Okay, what are the syndromes associated with the renal tumor?
like with Wiedemann syndrome,
Yeah,
and Wagner anomalies,
yeah.
and Dennis Rush
Okay.
syndrome.
So what do you find in Beckett's weight?
We see omphalocele and visceromegaly.
Yeah,
And,
before that,
uh,
you're talking about dysmorphic features,
enlargement of
isn't
the
it?
tongue,
So that is,
macroglossia,
yeah, then,
and we see a tumor, that Wilms tumor, and hyperinsulinism.
So you see
Yeah.
a big child.
Yes, ma'am.
There's a huge, bigger babies.
Yeah, yes, ma'am.
So
Yeah.
see, these so many questions the examiner asked you to get the answer out of you. So you should have told it yourself because you know the answer, right?
Yes,
Good.
ma'am. Yes, sir. Yes.
All the residents who come for this presentation should practice the presentation, I think, first among yourself, so that consolidate all the answers, so that we can go quickly in this, and you can gain out of the entire discussion, because otherwise this case discussion can take hours. But we have got limited time plus limited, uh, at this point of time, we have a limited time to enlighten you. Maybe we have to break the discussion for the next time also, but whatever maximum we can cover, we'll cover now.
Yeah.
Go ahead.
Yeah, go ahead. Go ahead with your systemic examination.
On abdominal examination, on inspection, a fullness was noted in the left hypochondrium and the left lumbar regions. The umbilicus was noted in the midline, which was inverted, and
May I interrupt? May I interrupt? In the
Yes,
general
ma'am.
physical examination, I would appreciate if you talk about pigmentation and any this thing, blotches or spots.
Yes, ma'am. I will tell now.
ठीक है? Okay, that is in the systemic examination. Fine. Abdominal examination, carry on.
There was a fullness noted in the left hypochondrium and the left lumbar regions, with the umbilicus in the midline and was inverted. There was evidence of engorged veins noted along the left flank, and there was no evidence of any scars, sinuses, or any visible peristalsis or pulsations. Hernial orifices appear to be normal, and there was no renal angle fullness. And on palpation, we could, the abdomen there was no local rise of temperature and the non-tender. We could see a 9 into 8 centimeters solitary mass in the left, occupying the left hypochondrium and the left lumbar regions, which was extending medially from the umbilicus, laterally merging into the flanks, and superiorly it was extending superiorly. There was no finger insinuation under the left subcostal region, and inferiorly the mass was about 2 centimeters above the iliac crest in the mid-clavicular line. And the mass was hard in consistency with an uneven surface and immobile in all directions, and it was not moving with respiration.
It
And
was immobile in all direction, like,
yes,
or mobile in all direction.
immobile, ma'am. It was not mobile in any direction.
Okay.
And upon head rising, the mass became less prominent, and on knee elbow position, it was not falling forwards. And in the rest of the abdomen, there was no organomegaly, and there was no renal angle tenderness. On percussion, the liver span was normal, and the mass was dull on percussion. And on auscultation, we could hear normal bowel sounds with no bruit. Rectal examination was normal. And coming to the rest of the systemic examination, respiratory system, the bilateral air entry was present with no added sounds. And cardiovascular system, S1, S2 sounds were heard with no other added sounds. And central nervous system, there was no focal neurological deficit. Spinal examination, uh, the spine was normal with no tenderness over the bodies. And musculoskeletal system, uh, musculoskeletal system, there were all the limbs had normal range of motion with no evidence of any bony tenderness.
I think you can just wind it off as systemic examination
On summary,
within normal limits. So if particularly asked, then you can tell that I particularly saw this. Now you
okay.
said that no focal deficit. What
Yes.
was in your mind that you said there is no focal deficit, neurological deficit?
Any motor deficiencies and any sensory loss.
What was in your mind before you did that examination?
I wanted to rule out any paraneoplastic syndromes associated with the neuroblastoma.
Okay, if
That
there
is
is something
abnormal
positive,
movement.
yeah, if there is something positive, then stress that and say. Otherwise, you can just say that
Otherwise, there is a high possibility of you falling into trap of this thing, abnormal questions.
nothing significant.
If
That's what Dr. Simi.
you speak too much about the systemic examination had it been normal, because if you say focal deficit, then I will ask you, are you expecting some metastasis in the CNS? Then which tumors are causing, and what is the age group in which that tumor occurs, and which tumor are you expecting? Because focal neurological deficit means you are thinking about metastasis, you know. So you have to be very careful, like presentation of the case is also an art.
Yes.
Even if you know everything, you may fall into bad traps. So be very careful when you present the case. If it is normal, then you should, but you should know that what you have to see, so that the next time the examiner poses a question, that what you particularly saw in the neurological system, then you should be able to tell.
Yes.
Right? As you said, the abnormal movement as you see in neuroblastoma. Anything else that neuroblastoma can cause, which will lead to abnormal, neurological examination, derangement, peripheral nervous system?
The opsomyoclonus ataxia syndrome.
That is a paraneoplastic. But
Yes.
neuroblastoma as such can also cause something which will lead to some abnormality of limb movements, lower limb movements particularly.
Paraspinal extension of the lesion.
Yeah, spinal extension can cause matters, and there could be
Cord pump.
metastasis as well as its extension into it. Okay,
Yes.
then you should, that should be in the back of your mind, that if
Yes.
what particularly CVS you said that there is S1, S2 normal and all that thing. What was in your mind when you did the systemic examination of CVS? Is there something which associated with tumor which can lead to some altered heart sounds or additional heart sounds?
Lesion is very huge and is occupying most of the abdomen. It may cause a diaphragmatic elevation and
More
So the
importantly,
question is on cardia. See, she's giving you hints. Question is on cardia. So anything in these tumors can cause a cardiac finding which you might pick up.
let it be Wilms tumor. Okay. Then you heart sound hearing is important. Why particularly?
Extension of the lesion into the IVC and from there to the atrial extension.
So thrombus can
Tumor
extend.
thrombus.
So
Yes.
so for each system, it should be in your back of mind why a particular thing is done. But if systemic examination is normal, you can say that heart sound normal and rest of the systemic examination with the normal. Is it okay?
Yes, ma'am.
Dr. Shubha, you can ask next.
Yeah. So would you summarize the examination findings and would you want to revise your diagnosis?
Yes, ma'am.
Yeah.
So this is a 3-year female child with an incidentally found flank fullness in the left hypochondrium and the left lumbar regions with a solitary mass, which was hard in consistency, uneven with an uneven surface and a immobile lesion. With the examination pointing mostly towards a retroperitoneal lesion.
So is it still the kidney?
No, ma'am. I would like to change it to a retroperitoneal.
Yeah. Why do you think it's not the kidney now?
Because lesion was not bimanually palpable.
Okay.
Because it's not very big, so it need not be bimanually palpable means it's a very large lesion.
And a renal mass should be moving with respiration. But
Okay,
this
what
lesion
else?
is not moving with respiration.
What else? What examination findings which you have noted down here say that it is not a renal mass?
Posteriorly also you saw something, no?
The renal angle fullness.
Okay,
That
so you
is one
did note
point.
there was no renal angle fullness or tenderness. Anything else?
And mobility of the lesion.
Okay. Can a renal mass be fixed? When can it be fixed? And if so, when can it be fixed?
It is a common things that they are asking you. So from your bedside experience, you should tell them. Is it common for a renal mass to be fixed?
No, sir.
Yeah, so it's uncommon. You said it is hard and something. So many features you have said which are not like a renal mass. That is why they're asking you these things. Yeah.
Yeah, you already have written down in your findings. So you just have to tell us why you now think that it is not a renal mass. One is you said it's not moving with respiration.
Yes,
you said it is probably fixed. Yeah, then what about the superior border?
The finger insinuation will be possible with a renal mass.
Okay. So here it is not feasible.
Here,
The
here it is not.
consistency is not hard. You're saying it's hard. So you're very specifically mentioned hard.
Yes.
So that is one point. And the renal angles are not full and they are not, there's no tenderness.
Yes.
So what is your diagnosis with this?
With this, I would like to give a differential diagnosis of a retroperitoneal tumor.
Okay.
or it could be a neuroblastoma, ma'am.
Yeah, okay.
Okay, both the things can be accepted.
Neuroblastoma, what else?
Uh, Other could be a possibility of a Wilms tumor.
But just now you said you don't think it's a renal mass.
Yes.
Yeah. So what else? You still had your differentials, no? At the level of history itself. You said neuroblastoma. You said something else in the retroperitoneum.
Teratoma, ma'am.
Okay, teratoma. So among these, what do you think is first? Would be first in your list?
Retroperitoneal teratoma, ma'am.
Why?
Why? What is against neuroblastoma then?
The clinical presentation, the child will be ill looking and they present in the early ages, and moreover, the lesion also will be a very large lesion occupying the central part of the abdomen.
But even retroperitoneal teratomas are also large lesions only.
Yes, ma'am.
Yeah. What is it that is very consistent with the neuroblastoma presentation? One is age, you said. What else?
The child is usually a ill-looking child
Yeah.
with a
So
large
constitutional
abdominal mass.
symptoms may be more.
Yes, ma'am.
And they may have some features on their general physical examination, which probably you didn't find here much. The child is generally well preserved, isn't it? At least from your
Yes, ma'am.
photo,
The
what you
child
can
is
see.
well preserved.
Yeah.
Though
So
fever is present, hai na? Fever has been continuously going on, na? For over the last 3 weeks. Okay.
The fever history was only for the last 1 week, ma'am.
Okay.
Previously, she never had any
Okay.
history of fever.
okay, so now you have retroperitoneal tumor high on your list as compared to your renal mass.
Yes.
Okay. How do you go about it?
I would initially like to get a ultrasound of the abdomen done.
Yeah.
To look for the site of origin, and also for the echogenicity of the lesion and its relationship with the surrounding structures.
Okay. Then we have some findings with us.
We have an ultrasound done now.
Okay, let me ask you one other question. Supposing this lesion would not have been fixed, could you have thought of some other things also?
It was not fixed.
Presume it is a female child.
Yes, ma'am.
It's a mobile lesion. With almost
Any
similar.
ovarian lesions.
Yes. Okay, fine. Can present like that. You should be aware.
Yes.
Very common presentation. Okay, now go
Yes.
ahead. What was the ultrasound finding?
The ultrasound finding was a 10 into 7 into 6 centimeters, well circumscribed hypoechoic lesion with lobulated margins, showing the vascular flow on Doppler, and a 30 mm echogenic focus with posterior shadowing noted in the left hypochondrium located between spleen and the left kidney. So they have given an impression of a large hypoechoic lesion with lobulated margins with vascular flow and calcifications in the left hypochondrium located between the left kidney and spleen.
Okay, but they didn't tell the site of origin still. So what is it?
Because the site of the lesion was inconclusive, now I would like to get a CT contrast enhanced CT computed tomography done of the abdomen.
Okay, so a large lesion with calcification, what would you still keep in your mind?
I would stick on to the same two DDs, ma'am. That is the retroperitoneal teratoma or neuroblastoma.
Okay. So
Okay.
what type of calcification do you find in either of these?
In the neuroblastoma, we usually see stippled calcifications.
Okay. And in teratomas?
So also we can see stippled calcifications.
It is a dense classification which is said as calcification. Okay.
Yeah.
Eggshell in Wilms, stippled in neuroblastoma, and dense in teratoma.
Yeah.
That is how it is described because they're bony tissue around.
Yeah. So what are the things in teratoma which present with calcification or which are picked up as calcified areas?
Any cartilaginous structures and any
So a little more than cartilage. Cartilage will not have calcification.
You have heard of organoid? They're trying to get that answer from you. What all calcification? So have you heard of organoid calcification in teratoma? Give one example to them.
Yeah, commonest thing, no? You would have seen lots of teratomas, no? When you dissect it or like cut it open, what would you find commonly? So calcification in a teratoma is good or bad? Sir said organoid, so it means what?
Has she lost the connection? Hello?
Hello, Sai, are you there?
I think she is not able to connect.
Oh. Okay, anyone else? Organoid calcification?
So the axial skeleton is seen in
Okay. Teeth,
okay.
bone, etc. And is it good or bad?
So it is good. It signifies
Okay.
benign pathology. Like
Maturity. Okay, fine. Is she back? She had to show us a CT, she was saying.
Can we have it next time then?
Yes, we can, I think.
Because it's almost been 1 hour.
9, going to be 9. Is she joining with us? No. Okay, I think we will wind up. We will do the session the next time, continue from there. Or
Hello, sir.
yes.
She's come back.
Sir,
She'll come back. Okay.
sorry, sir, there was
Fine.
a problem with the network connection.
Fine. Go ahead.
Ma'am,
Yes.
You have some of them, Sai, on the CT?
ma'am, these are the CT films, ma'am.
Yeah. Please go ahead and describe.
This is a plain CT of the axial sections. We can see a heterogeneous lesion which is occupying the left part of the abdomen, ma'am. And we can see few calcifications within the lesion. And the lesion has pushed the spleen to laterally and the kidney downwards. And on contrast, we can see a well demarcated lesion which was crossing the midline and pushing the pancreatic structures and spleen and the left kidney. And the tumor is encasing the aorta as well as the superior mesenteric vessels. And it is having clear margins with the left kidney. Both the kidneys appear to be normal, and the liver appears to be normal now. And the this vertebral part, which the body of the vertebrae which are present throughout the films appear to be normal now.
Okay. So, what is the importance of a plain CT and a CECT in this particular tumor?
To look for the relationship with the vascular structures.
In the contrast CT. So,
Yes, ma'am, in the
what information does the plain CT give you?
On the plain CT, we get to know the heterogeneity of the lesion, whether it is a homogeneous or a heterogeneous lesion, where here it is a heterogeneous lesion.
Yeah. What else? One is, I think, you get to know the site.
And we can know the site and its relationship with the structures, and also any calcifications.
Correct. The
Yes.
relations, I think, are
Calcification is
better
important.
delineated on a contrast CT. So the plain CT mainly tells you the site and probably the site of origin, the nature of the lesion, and presence of calcification. So if you have to comment on the, as you rightly did, which you have to comment on the surrounding structures, yeah, and the relations, probably it is better done on a contrast CT.
Yes.
Okay. Okay, in contrast CT, in neuroblastoma, which now you think it is, that is the diagnosis, what are the things which have a prognostic value?
I didn't get you.
No. So you said the relations you have described quite well on your CECT. Which of these have a prognostic value? Does it guide your management?
Yes, ma'am.
What are those?
Relationship with the vascular structures.
So what are they called?
She has given you a hint. She has given you a hint. She said guide. So you must jump and take the clue.
Image-derived risk factors.
Yeah. So when you're talking about neuroblastoma, we are looking, when you're describing the relations and its vascular anatomy with respect to the tumor, you're mainly looking at image-defined risk factors, because that is going to have a prognostic significance and probably it guides the way you're going to manage it.
Yes, ma'am.
Yeah. Okay. So now you tell me, what are the relations which have been significant on this CT and which are the image-defining risk factors, image-defined risk factors?
The encroachment of the, encasing of the superior mesenteric vessel and the encasement of the aorta. Yeah. According to the images, these two are the image-defined risk factors for this case.
Which you have documented here. And what is, what else is will tell you about your prognosis or your staging rather?
In view of image-based risk factors.
No, that is apart from the image-based risk factors, image-defined risk factors. With respect to relations, one is you talked about the extent of the tumor. Does it have a bearing on your management?
Any paraspinal extension.
Okay, that is one thing. What else?
And crossing of the midline.
Okay, so is it important?
Tumor size.
Yes, ma'am.
Yeah, tumor size, whether it's crossing the midline. What else?
Yes. Any lymph nodal involvement.
Yeah, and you told that when you were talking about all the CCT findings, you
Yes.
did describe it.
The involvement of the other solid organs.
And the bones also you mentioned, na?
Yeah, yeah,
Paraspinal
bone and the
extent.
liver. You talked
Huh.
about the bone and the liver. So roughly
ma'am.
all this will help you in your staging as well.
Staging
isn't
of
it?
the system. Yes, ma'am.
And
Staging of
probably
the.
to guide you in the way you're going to manage this.
Yes, ma'am.
So what were the discordant findings in this particular child? Now we, by and large, are I think focusing on a diagnosis of a left neuroblastoma, adrenal neuroblastoma. Okay.
Yes, ma'am.
So what are the findings which were discordant from history to now till the CT? We still didn't discuss biochemistry anyway, but yeah. No, we've already discussed it. We just need to revise it.
That the child is well preserved, the age is not favoring this diagnosis. What else?
Yes, ma'am. It's a 3-year child with an incidental finding, which is,
Correct.
and then the child is well built.
Yes.
Well
preserved.
And well preserved, and
BP is also within normal limit, you said.
yes, ma'am.
And clinically, did you did you feel the mass was crossing the midline? What you're seeing on CT?
It was just up to the midline, sir. It was just up to the midline.
So yes.
Yeah. So how do you go about it now? What extra information would you need apart from imaging?
In order to risk stratify or in order to stage the tumor, I would further need a histopathological diagnosis of
No,
the.
but before histopathology, neuroblastoma has a lot of things.
Before going into something, you do.
I would like to do the tumor markers also, ma'am.
What?
I would
what
like to
tumor
get
markers?
a urine spot vinyl mandelic acid done, and
So will you do that, or
24
will you straight go to get your diagnosis with the biopsy?
I would do both simultaneously,
You
sir.
will do both simultaneously. Okay, fine. Go ahead.
Would
Go
like
ahead,
to
go ahead.
send. I would like to send samples of urine for 24-hour urinary vinyl mandelic acid and also urine spot vinyl mandelic acid, and then
Why
meanwhile
both?
would
Why not
plan-
one of them? Why not just spot? Fast, easy. Any difference between the two?
the specificity is different. It's less with the urine spot PFS.
Okay, go ahead. You must know this. What is the difference between the two?
Yeah. So what do you have in this child?
In this child, the urine spot PMA was negative now. And the 24-hour urine vinyl mandelic acid was 4.9 milligram per 24 hours, which was elevated.
Okay. So how do you explain this?
If VMA is not elevated, can it still be neuroblastoma?
It can be, ma'am.
Then why VMA won't be elevated?
Because I mean, 10% of the tumors, they do not secrete any catecholamine, so it could be a
Yeah, it could be
neuroblastoma.
alternate type, which yeah. Okay, fine.
So here your VMA is elevated means what?
The lesion is secretory of catecholamine, so it's
yeah. But what else does VMA tell you?
Is there some ratio also which is more informative for prognostication?
Is it more mature, less mature compared to HVA? That's what they're asking you about. By now, you should have told them that.
So more mature, sir, if it's positive.
For if there is high VMA or high HVA?
High BMA is more
Is
mature.
better. Okay, fine.
Yes, ma'am.
Okay. Then what next? You are also going to take the biopsy. Is it not?
Biopsy.
So what all
Yes,
you are
ma'am.
going to see in the
Uh,
biopsy?
So
What
you
is expected?
want to biopsy or you want to operate? You want to excise?
Which type of biopsy if you want? I mean, that is also important.
I would like to plan for a true cut biopsy, ma'am.
By which route?
To a mini laparotomy, we would plan a true cut biopsy.
We need laparotomy. Why you can't do it in some other guided way?
Already got the CT done. Ultrasound
Yeah.
is
It's a
there.
huge mass. It's palpable.
We can take
Yeah, you have so many windows.
CT
You can
guided
take.
CT guided biopsy can be.
Yeah, CT, even ultrasound, it is so large a mass, you have so many windows posteriorly in the flank to take.
Yes.
Do you do
Yes.
true cut biopsy in your center or not?
We do it, ma'am, but we usually do it in a theater, ma'am. Radiologically, we have one.
Fine, fine. You can say whatever you do in your center. No.
Yes.
So
the
will you
way
only do biopsy or will you do something else along with it also? Since you are going to give anesthesia, as you said, will some
we
other
can,
painful investigation you will do along with it also?
which again has a risk stratification role. What would you do along with the biopsy? Either your open biopsy or ultrasound guided true cut biopsy. What else would you add on to that procedure?
uh,
Yeah, somebody has written there bone marrow. No? You do a bone marrow biopsy, no? Don't
bone
you
marrow
want to do that?
biopsy.
Yeah.
Yes, ma'am, bone marrow biopsy.
Yeah. So do you have these reports with you?
No, ma'am, we haven't done a bone marrow biopsy, and the tissue biopsy is about to come on. It's pending.
What do you expect in tissue biopsy of neuroblastoma? Generally, what will be the finding?
We see a small blue round cell lesions will be there, ma'am, with a pseudo rosette formation.
What else do you want to see in the report? Just tell us 1, 2, 3, 4, what all you want to read in that report and find out. One is the morphology, what you are saying, right? What
Yes, sir.
else?
Which has
Some
got the
particular-
prognostic significance also.
We look for the histology of the lesion.
Correct. So that what exactly in the histology, what do you want to see? For example, in Wilms, we want to see whether it's triphasic, biphasic. We want to see whether there's anaplasia. Here like that, what do you want to see?
There is one classification based on that.
Yes, ma'am.
Okay.
Ganglionic.
Yeah, you want to see how differentiation
Ganglionic
is there.
neuron. Yes.
Okay.
Yes, sir.
Okay. Ganglionic differentiation, Schwannian differentiation. So more towards the mature side or immature side. That is one. What else?
Yes.
Something else, some indices?
The DNA index we look for, sir. Mitotic carrier excess index.
Okay. Okay. MKI you want to look for, like. Right. So
Yes.
these are some of the things that you will see: nodule formation, etc. Right. Okay.
DNA, which type of DNA amount is considered to be good for neuroblastoma baby?
Hyperdiploid is considered good for
Okay.
neuroblastoma.
Fine.
Right. Anything
and
else you want to do? One more thing.
On the tissue again.
Again on the
Any
tissue.
endemic amplifications.
Oh, okay.
And
what is endemic?
it's a proto-oncogene, ma'am.
Where is it found? Which chromosome? You should know that. Okay.
Yes.
Read for yourself. It makes the foundation of prognosis. Nowadays,
Yes.
it is the risk-based neuroblastoma classification has that as very important factor. At least you should know in and out about NMIC. You can get a short note also.
Yeah, just like AFP, you must know everything. HCG, you must know everything. NMIC, you must know everything.
Yes.
Fine.
Shall we wind up the session?
I think so. I'm tired now.
Yeah, I think both of you have to give her an assessment as clearly passed, borderline, or otherwise, and so that she will know how to climb up.
Yeah, so she's been borderline side, so not to discourage you, but you have to be more prompt when you talk.
Yes, ma'am.
Yeah, because you know the case. I mean, we never knew the case. We've not even seen the child. So
Yes,
you have
ma'am.
to be very confident when you're presenting, and you know
Yes.
many things. But it's a good idea to sort of make a note in your mind as to what are the general physical findings in the common solid tumors in children, because those are the common masses which come for exams.
Yes, ma'am.
And make a list of things, what happens in benign condition, what happens in malignant conditions, which are very synchronous of a particular malignancy. So all these things, if you make a note, when somebody asks, you'll be able to tell, I mean, you will be able to tell non-stop. You should always have it on the count, on the fingers.
Yes.
Otherwise, you have performed well. Otherwise, you have performed well. Your findings are matched with the investigations also. So that way it was good. You led to a proper diagnosis.
Yeah, your examination findings were very accurate. Yeah.
Yes.
Okay, Sai.
Okay. Thank you. Thank you all.
All the best. Yeah. Thank you, sir.
Thank you, ma'am.
Right.
Please mark out of 10 that we had decided. Mark out of 10.
Yes, Shubha has to say, and Dr. Simi has to say.
Yeah, maybe 6 to 7.
I think
6. I will mark her as 6.
Yeah, between 6 and 7, maybe. Yeah.
Thank you.
okay.
Yeah.
Thank
all
you.
the best, Sai. Thank you. Thank you, sir.
Thank you, ma'am. Thank you.